Hi, I'm Cecilia Stuopis. I am the Medical Director at MIT Medical, and I'm happy to be here with you today discussing translational research, making meaningful impact for patients, practice, and populations. I'm very happy to be here with the SENSE.nano 2021 Annual Symposium. First, for disclosures, I have nothing to disclose. I'd like to start off this presentation with a story. A little bit of it is about me, but a little bit of it is also about why the research that you all are doing is so important. This is my home state, Nevada. It's a very large state, and it has two major urban centers in Las Vegas and Reno, but the rest of it is entirely rural. Nevada is a state that you could fit almost all of New England and part of New York into without any difficulty if that was something that one wanted to do. I grew up in Las Vegas, and from there I came to MIT to pursue a degree in aeronautical and astronautical engineering. You might be wondering how I got from there to being an obstetrician gynecologist. Well, that is a story for another day. But suffice it to say, after a couple of years working as an engineer, I had a change of heart and wanted to go to med school. From there, I headed back to Reno to go to the University of Nevada, Reno School of Medicine. It was a great school for me. It was very small. There was a lot of hands-on experience. And one of the major missions of my medical school was to be able to produce doctors who could serve the population of Nevada. And that included the rural population of Nevada. We were all required to do a rural family medicine rotation. I had mine in Winnemucca, Nevada at Humboldt General Hospital. This was a tiny critical access hospital about 2.5 hours east of Reno on I-80. I worked directly with a family medicine physician there who had a couple of other partners, and they were the healthcare for the entire hospital and for this little town of Winnemucca, Nevada. And as part of that, he covered the ER, he had clinic and saw regular primary care patients, and he did full scope obstetrics, including prenatal care and vaginal deliveries and cesarean deliveries. And while I was there, I had the opportunity to scrub in on the cesarean delivery for a mom who had a very premature baby at about 30 weeks and her baby that was born. And one of the things that struck me at that time was that being born in a rural community, especially if you were premature, was a very risky endeavor. That baby had to be helicoptered back to Reno so that it could be cared for. From there, I went on to The Ohio State University for my OB/GYN residency, and we served a different kind of rural population there, a population that really was from the hills of Appalachia. They would be transferred into our hospital all the time. So this rural population has always been part and parcel of my work, including when I eventually moved to New Hampshire to take my first job. New Hampshire is also a highly rural state, even though it's close to a major urban center like Boston. Back in 2014, I had the opportunity to start a new educational venture at the Master of Healthcare Delivery Science program at Dartmouth up in Hanover. And this program is a joint program between Dartmouth Medical School, the Tuck School of Business, and the Dartmouth Institute for Health Policy. My very first day, I met Ben Anderson, who at that time was the CEO of Kearney County Hospital in rural Lacon, Kansas. This is in the far western part of Kansas, and this hospital is also a critical access hospital. And you can see how far west it is. It's practically in Colorado. The other major cities, Wichita here and Kansas City to the far east, are very far away from Lacon, Kansas. And one of the issues for this hospital was that they didn't only deliver patients of Kearney County, they also delivered patients from 12 other counties. And one of the things Ben talked to me about on that very first day upon learning that I was an obstetrician was that he had concerns over the high rate of gestational diabetes within their immigrant population. And he wanted to know if I had any thoughts on how they could improve care for women at their rural hospital, which was run by family medicine providers, much like the hospital I had been at in Winnemucca. We talked a bit, and one of the suggestions I had for him was to think about partnering with one of the universities where there were maternal fetal medicine specialists to see if they could somehow support the practice of obstetrics out in Lincoln, Kansas. And perhaps that would be by coming out to do clinic, perform ultrasounds, support the doctors, update their skills, anything that it would take to help these doctors and these women have the best possible outcomes. Within 6 months of that first meeting, that evolved into what was called the Pioneer Baby Program. And they saw meaningful results from this program, which involved a partnership with them and the University of Kansas School of Medicine, and those doctors coming out to Kansas several times a month. That led to higher vaginal birth rates in women who'd had cesarean section previously, and it also led to an 11% decrease in fetal macrosomia, which is the marker that goes along with gestational diabetes. Women who have gestational diabetes often have very large babies. That led to better outcomes for moms and their babies. So what does this have to do with why we're here today, talking about translational medicine? Translational medicine is critical to improving the care of our population here and abroad. And I think Dr. Zerhouni said it very well back in 2009 when he was the 15th director of the NIH. He said, "Our country needs more and better translational research, both for the sake of our patients and because much of the research funding in the United States comes from the primary expectation of the American public that such scientific investigations will reduce the burden of disease." And that last part is critical. How are we going to reduce the burden of disease? And I would argue, keep people well as well. Let's talk a minute about the concept of translation. Like many of our words, it comes from Latin, trans, across, and latus, born or carried. This means carried across. So in our case, the information is carried across. It's used with both non-scientific, like linguistics, and scientific, like the synthesis of proteins from mRNA, connotations. As it relates to biomedical research, it is the process of turning observations in the laboratory, clinic, and community into interventions that improve the health of individuals and populations, from diagnostics and therapeutics to medical procedures and behavioral interventions. So it uses the word process, meaning it's multi-step. Observations, they start with perceptions from any of those places, not just from the basic science lab bench. Much of our successful translation begins with a clinical or public health observation that leads to a basic discoveries. It is a bi-directional process by its nature. And the interventions can be of any modality. It's not just a technology or a pill. It can also be through behavioral modification or other interventions like education. We should talk a moment about translational research at MIT, since this is an MIT conference after all. In 1964, MIT established the Clinical Research Center to provide clinical services to support the application of basic science and engineering to the study of human physiology. And the CRC at that time was partnered with MIT Medical and continued in that fashion for many, many years. The next major change came in 2018 when MIT announced a collaboration between MIT and the Tufts Clinical Translation Science Institute, which aims to accelerate device development for clinical studies. This was interesting in that they were specifically in this partnership going to look at the T.5 capacity in medical devices program with our partners at IMES. And this was focusing on an early yet critical stage in translational science when a medical device is in the prototype stage, so not yet ready for prime time, perhaps in a clinical trial. And then in 2021, right now, the MIT CRC has evolved and expanded to become the MIT Center for Clinical and Translational Research. And it has moved from the School of Engineering into the Vice President for Research portfolio. There is a symbiotic relationship between basic and translational research. When we talk about translational research, we start with the T0 phase, the basic science research, and it goes all the way around the cycle as information is gained and studies are completed. In the T0 to T2 phases, This is really where we are translating the basic science into humans and then into clinical trials that are hoping to demonstrate efficacy. In these three areas, we are defining mechanisms, targets, molecules, new methods for diagnosis, treatment, and prevention, and we have controlled studies, again, to demonstrate efficacy. As we get into T3 and T4, this is the translation of this new data into the clinic and into health decision-making. And what we're aiming to do is have the delivery of recommended care be timely and go to the right patient. And really, at the end of the day, what we're hoping for at the T4 level is population level outcomes research that demonstrates a true benefit to society. Unfortunately, there's a lot of research that never gets to T4. You'll also see in this diagram the arrows going from each of the steps back to the basic science bench research. At any point along the way, information can be learned that will produce further questions for the basic scientists to begin their research once again. There's another way to think about translational research, and this schematic from the National Center for Advancing Translational Sciences puts it nicely. It also maps well to a current clinical care model that is predominant in the US called the patient-centered medical home. And in both of these, the patients are at the center of the process. You'll see that there are relationships between all of the entities that are involved. And they are important because together, their goal is to develop new and useful approaches to demonstrate their usefulness and to disseminate those findings for the good of individuals, clinical practice, and public health. So fundamentally, translational research and relationships are the key. They're the key for meaningful impact for patients, for practice, and for populations. So let's take each of those in turn. So for meaningful impact for patients, what does that look like? And I think the question here is, who are we trying to help? How does the research community view people we are trying to help? Are they subjects? Are they patients? Are they something else? A subject is defined really in a regulatory fashion from the regulations that govern biomedical research in humans. But it's pretty sterile, a living individual about whom an investigator conducting research obtains information or biospecimens through intervention or interaction, and uses, studies, or analyzes the information or biospecimens, or obtains, uses, or studies, or analyzes generatable private information. That's one view. Then there's the patient view. In general, a patient is a recipient of healthcare services from any healthcare provider. But let's talk about what the word patient means. Again, we turn to Latin. The word patient comes from Latin patiens, which is from patior, which means to suffer or to bear. So in this language, the patient who is suffering or bearing, those are passive. Something is happening to them. Is that who we're trying to help? Or are we trying to help a third option, the active participant? And this is the individual we should really be thinking about, an active and engaged participant in healthcare who has the goals of restoring, maintaining, or improving their health. I'd like to take a minute just to talk about patient-centered outcomes research. It's related to aspects of translational research, particularly in the T3 and T4 zones. It includes the perspective of end users of the research, including patients, physicians, and other healthcare stakeholders. And really, we want in this model to have the evaluation of questions and outcomes meaningful and important to patients and caregivers be central to the process, because we want to recognize that they have unique perspectives, values, and goals for what we are trying to learn or accomplish. When we use a patient-centered outcomes perspective, we are including their perspectives and thus enhancing the relevance of research to the actual health decisions that these patients, their providers, and their caregivers face. And when that happens, this yields increased relevance, which improves the uptake of the evidence that has been generated and improves the likelihood that patients will achieve the health outcomes that they desire. And that is critical. A strong theme here about engaging patients, both at the clinic level and in the research that generates these clinical recommendations that we're trying to use. So building relationships with patients is key to engaging those very same patients or active participants in the research. A paper by investigators at the University of Maryland looked at the features of highly engaged patients. On the x-axis, you see the timelines of engagement from less than 2 weeks all the way out to more than a year. On the y-axis, you can see the level of engagement on the part of the participant, from what they call a passive engagement all the way up to an authentic engagement. Passive, in their parlance, are those individuals who are really regarded as subjects by the investigators. It's very researcher-driven and unidirectional in nature. In the mid-frame, they talk about a tokenistic engagement, where the patient serves as an advisor, but is not integral to the process per se. And then in the authentic type of engagement, the patient is a co-investigator and co-developer of the research, ideally from early on. So as investigators, if you are going to engage with patients in meaningful ways, the research from this paper suggests that engaging with patients earlier in the process and partnering with them as co-developers and investigators is the secret. And you want to be right up here in this upper right-hand box. So what does this look like in practice? In a more granular way, this type of a fruitful partnership could impact so many areas of the process, from topic selection and prioritization, to recruitment and data collection, to dissemination and implementation of the findings. For example, we could look at recruitment and data collection. If there's early partnership with patients, you could identify potential challenges with either recruitment or data collection, things that just won't work for the subjects that you are trying to study. But on the other hand, if we collaborate with patients more intentionally in study design, we could co-develop recruitment strategies and data collection protocols that have higher chances of success. So translational research impact is meaningful for patients when there are strong relationships between the patients and the investigators, when patients are not merely subjects, but are involved and engaged participants in the research, and when the interventions that are studied and the questions that are asked matter and improve their health. Let's move on now to talk about how we make a meaningful impact for the practice of medicine and healthcare. So while you all have continually advanced in your day in and day out use of technology in the laboratory and increased the capacity you have to do complex work, things have not kept up in the clinic. And this author states, and I think rightfully so, that the capacities and activities of the basic research laboratory are virtually unrecognizable compared to 40 years ago. But the capacities and activities in most medical practices remain largely unchanged, and translation has become progressively less productive over time. So what a physician or healthcare provider does today in the clinic does not look that different from what Marcus Welby did back on TV in the 1960s, with perhaps the exception of the ever-present electronic medical record. Speaking of those visits, there are a lot of visits that happen in the clinic. There's a world of opportunity for you as researchers in our ambulatory clinics to access patients and providers and to gain their insights. This is the most recently available National Ambulatory Care Medical Survey. So that doesn't even take into account all of the care that happens in hospitals. In 2018, there were 860 million visits, half of those with primary care providers. And that worked out to almost 2.7 visits per person. Where do those visits happen? Again, the same survey provides some insight here. The largest portion of these office visits are in private or group practices. That's the large purple section. You'll note that the orange section, with 1.4% of the visits, is the medical or academic health center. So here, what we have learned is that most patients get their care outside of academic medical center settings that are predominant in the Boston area. Most providers in practice really don't do research in their day-to-day work. And providers in the field, so to speak, are not always certain that the findings that they are getting from research are translatable to their practice setting. The average practice setting does not look at all like Cleveland Clinic or MGH or Mayo. So how do we help them? Once again, we go back to the concept of engaging the physicians in the questions that matter to them and their patients. Translational research offers us this opportunity to work directly with physicians and other healthcare providers. You'll be familiar with the concept that many clinical trials end in futility after failing to recruit and retain the required number of participants to get statistically valid results. You will also be familiar with the frequent underrepresentation of racial and ethnic minorities in clinical trials compared to their population and disease prevalence. And these numbers have not improved appreciably over the last quarter century. So clinical trials, whether sponsored by industry or government funders, they have limitations. They don't always address the clinical questions that are needed for improved care of patients, and they may be focused on answering questions of interest to the academic investigator or to the funding entity. So with engaged physicians, there are many possibilities for you as the researcher. They provide real-world data and insight to you on the questions that you're asking. And remember, they remain curious as well. They have questions they would like answered. So broad collaborative relationships between researchers and providers might develop pipelines to patients who otherwise could not access clinical trials. And partnering with physicians outside of academia has the potential to enrich the research process. And as a byproduct, we could develop new physician scientists. So translational research impact is meaningful for providers too. When there are strong relationships between the researchers and the providers, when those same providers are involved and engaged collaborators in the research, and when the interventions studied and the questions asked matter for the care of their patients. On to the populations. How do we impact populations? We are all familiar with the concept of bench to bedside. That is the core fundamental tenet, I think, of translational research. But what does this look like in reality? So introducing new interventions, medications, and procedures disrupts the equilibrium in a clinician's practice. Not only do those practitioners need to incorporate the new, in many instances, they need to unlearn the old. Adopting new practices is also affected by the many other inputs in decision-making. We think as physicians, first, do no harm, and if we're uncertain about the research, why not use the tried and true? We use concepts of shared decision-making where we engage the patient in the decision-making process, and sometimes their decisions aren't aligned with what the newest evidence says. We have infrastructure realities in terms of how our clinics are run and the operations and insurance. There are payment models that disincentivize using the newest and latest and greatest evidence. Our individual experience with patients similar to this currently or in the past. And the concept that medicine is not always a science, but it is often an art. Those all affect decision-making. And then 17. It has been estimated that an average of 17 years go by between the time an intervention is shown to be effective and the time that it is broadly adopted across practices for all the patients who could benefit. This is what we call the research practice gap. And the research practice gap affects the health of populations. It's multifactorial in nature. We've covered a couple of these. There's this culture of physician autonomy, needing to unlearn the old ways, an erroneous application of shared decision-making principles wherein a physician or other provider might present the options to a patient, but not really provide all of the evidence behind those options and allow the patient to make a decision on their own without a lot of guidance, payer models, and more. We need to think about translating this into a translational research model as well. And these authors did just that. In their model, they redefined the endpoint of the pathway away from the incorporation of an intervention that has been declared effective into routine clinical practice, because that's not enough. The true endpoint should be the improvement in the health of populations. So this schematic attempts to place translational research into a public and population health framework. Across the bottom are the major steps of translational research, and you can see the complex interplay between that research and all of the other involved stakeholders. And in this population health ecosystem, there are many more stakeholders, and a constant synthesis of the available evidence is required. You can't just do it every other year. It has to be constant monitoring for what is coming through the pipeline. And indeed, we've seen some aspects of this schematic in practice over this last year and a half with the COVID-19 vaccine development, trials, and distribution, and the many inputs from all different areas into vaccine policy and the associated operational impacts of getting vaccines out to the population. So I ask you, what could it look like if research began with the end in mind? Often, our research questions are geared towards a singular condition that might in fact impact individual patients, that then might lead to provider impacts and population impacts. But what if we began with research questions that were trying to address population needs that then trickled back down to the provider and then to the individual patients? Would it look different? Would the things we learn get operationalized and put into practice much more quickly? I don't know, but it would be interesting to find out. So translational research impact is, again, meaningful for populations. When we leverage our relationships between researchers, patients, providers, and their communities, when communities and researchers come together and are involved and engaged in the process, and when improved population health is the primary endpoint. I have a few concluding thoughts, and I'll start with basically, I think that we need to optimize and leverage translational research to improve the health of individual patients, improve the practice of medicine, and improve the health of entire populations, that most importantly. Let's take a minute to go back to Kearney County, Kansas once again, and we'll look into the future now. A group of researchers, perhaps from MIT, learned that neonatal outcomes for infants of diabetic mothers in rural areas are significantly worse. And they began considering projects encompassing basic science, sensors, AI, behavioral change, more. You partner with the CTSI housed at the University of Kansas, and together you engage with both patients and providers across multiple states with significant rural populations to learn what barriers are faced and where the opportunities are. Meanwhile, the family physicians at Kearney County Hospital are eager to improve the care for pregnant women with gestational diabetes. They serve as your thought partners and collaborators on the research team and provide clinical insights that you can't have on your own. Patients with diabetes or risk for gestational diabetes are engaged very early to discuss what types of sensors, behavioral interventions, and technology they'd be willing to use and in what circumstances. And the physicians assist in recruiting pregnant patients. The patients are excited to collaborate and develop the research protocol. From this, several research questions are developed and some modifications to existing technology are made. A new multifunctional blood glucose sensor is developed that performs non-invasive blood glucose monitoring, but it also can monitor fetal heart rate and maternal neurotransmitter levels, all of it managed from a cloud-based app. With AI, you're able to learn what combinations of these things are predictive for good outcomes and which indicate things aren't going so well. And it becomes clear that this approach is making a difference for pregnant patients and their babies in rural areas. And ultimately, this approach is rolled out to a high-risk population of patients in both rural and urban areas. And the result is that perinatal and behavioral health outcomes steadily improve for pregnant patients and their babies, and their long-term health risks improve too. So think big. What problems could we solve by engaging patients, physicians, and entire communities in translational research efforts? Could we solve mental health issues and make some movement there? Can we improve neonatal and maternal morbidity and mortality? What other things can we do? So thank you for your time, and I'm happy to take any questions that you might have.